The manufacturer's label gives the name and dose, but won't stop a patient swallowing an inhaler capsule or incorrectly storing antibiotics. Auxiliary labels are the final safeguard. Pharmacists analyze 3 risk categories: severe, high alert, or LASA warnings, specific routes, and exact storage environments. We are going to test this framework against 10 real-world clinical scenarios to build your intuition for spotting hidden medication risks. Selecting the correct auxiliary sticker requires looking past the physical pill to identify the exact human vulnerability in how it will be administered. Take an IV infusion of norepinephrine. The manufacturer clearly labels it, but this drug requires 2 crucial interventions. First, an error with this drug can quickly cause a fatal outcome, so it mandates a high alert label. Second, its spelling closely mirrors epinephrine. A look-alike, sound-alike, or LASA label breaks that visual illusion for a rushing nurse. This exact logic applies to ICU drugs like dopamine and dobutamine. When a pharmacist dispenses both to different patients on the same shift, identical prefixes and suffixes create massive risk. A LASA label is the single most important tool to prevent a deadly mix-up in a high-stress environment. It is easy to assume these severe warnings only apply to intravenous medications, but dispensing warfarin, a simple oral tablet, carries the exact same high-alert requirement. Dosing errors with a 5 mg warfarin tablet can cause life-threatening systemic bleeding or clotting. Oncology drugs compound these risks even further. An order for alemtuzumab requires overlapping warnings to close every vector of error. It is a chemotherapeutic agent, a high-alert medication, a LASA drug, and it requires a strict not-for-oral-use warning. The physical form of a drug does not dictate its danger. The systemic consequences of a clinical misstep dictate the necessity of our interventions. The physical shape of a drug often misleads patients. When a nurse accidentally administers a tiotropium rhodocap orally instead of via an inhaler, they fall for the pill versus capsule illusion. A capsule form factor implies swallowing, which is why dispensing this requires both not for oral use and for inhalation use only labels. Beyond physical misdirection, we must flag systemic clinical risks. If a gynecologist prescribes doxycycline to a patient, an allergy alert is only part of the profile. Tetracyclines are teratogenic, meaning they are unsafe in pregnancy. That specific warning is non-negotiable. This chart shows the pharmacokinetic risk of altering a drug's physical state. We are looking at a slow, steady release curve for a metoprolol succinate extended-release tablet, compared against a massive, dangerous spike in drug concentration if that same pill is crushed. If a patient uses a pill crusher on this medication, they bypass its safety mechanism entirely. They will experience immediate dose dumping, resulting in rapid cardiac toxicity. A "do not crush or chew" label prevents this specific mechanism of failure. Altering a medication's intended physical state or administration route turns a therapeutic dose into a toxic one. Environmental factors present another vector for medication failure. A patient returning insulin glargine because it looks cloudy is actually describing a ruined drug. The physical change indicates the insulin was frozen, destroying its efficacy. A "keep refrigerated, do not freeze" label prevents this handling error. The immediate clinical environment also dictates handling rules. Dispensing cisatracurium to a receiving nurse in the ICU requires an immediate intervention. It is a paralyzing agent. It must carry a warning that it is for use on intubated patients only, or it will cause rapid respiratory failure. Let's test this logic. A prescription for amoxicillin clavulanate reads "dispense dry powder." The caregiver is a first-time parent. What specific combination of preparation labels is mandatory here? You cannot assume an inexperienced caregiver knows to add water to a dry powder bottle or how to store it afterward. This dispensing requires both reconstitute before use and refrigerate after reconstitution labels. Proper storage and preparation instructions bridge the gap between a clinical intention and a patient's safe execution at home. Let's apply these rules to a complete clinical scenario. We have a 45-year-old male with prescriptions for metformin XR, cetirizine, and ibuprofen. First, we apply our dose dumping logic. Metformin XR is an extended-release formulation. Bypassing that mechanism risks severe consequences, which mandates a don't chew or crush, swallow whole label. Next, we mitigate the known side effects of the remaining drugs. Cetirizine is an antihistamine that requires a may cause drowsiness warning. Ibuprofen is an NSAID that can cause gastric irritation, requiring a take with food label. To lock this in, run every future order through a 3-step cognitive framework. Ask yourself, is this a high-risk or look-alike drug? Is the physical form confusing the administration route? And will an environmental or state change ruin the medication? Mastering auxiliary labels is how you spot human vulnerabilities before they become clinical emergencies. It is how a pharmacist actively protects human life.